Good afternoon, everyone. My name is Hsien Min Low, Dr. Hsien Min Low from Tan Tock Seng Hospital, Singapore, and it's a great pleasure to be invited to this conference to present to you this presentation. So today I'll be going through an approach to small bowel obstruction. I have no disclosures to declare. So the outline of my talk is as follows. I'll be going through some imaging modalities, the diagnosis of small bowel obstruction, some causes of small bowel obstruction, the complications, as well as some useful advice for radiologists. So small bowel obstruction accounts for about 20% of acute abdominal presentation, meaning to say that it's actually quite a fairly common condition on call. Clinical features will include vomiting, constipation, abdominal distension, guarding tenderness, as well as tinkling bowel sounds to absent bowel sounds from auscultation. In terms of imaging modalities, radiographs are a good first-line modality. It is easily available, and the diagnosis can be made when there are dilated small bowel loops greater than 3 centimeters in diameter. You can potentially detect some complications such as pneumoperitoneum, pneumatosis, intestinalis, as well as aerobilia. However, CT remains the main imaging modality in order to evaluate these patients further. It is fast to perform. It also gives confirmation of the diagnosis. At the same time, it can also evaluate for the cause of the obstruction, look for any complications. Most of the time, it's performed with intravenous contrast and no positive oral contrast is administered. In terms of the causes of small bowel obstruction, it can be divided into the following causes. Intraluminal causes, meaning to say that the cause of obstruction is located within the lumen of the small bowel. Intramural causes, which as the name suggests, is due to an abnormality arising from the wall of the bowel loop. Extramural or extrinsic causes, meaning to say that something that is outside the bowel loop and is causing obstruction, as well as functional causes, and that would include things such as paralytic ileus, systemic diseases, as well as, in some rare cases, afferent loop syndrome. So we move on to the intraluminal causes of small bowel obstruction. The first one that I'm going to talk about is gallstone ileus. This occurs when gallstone erodes through an inflamed gallbladder wall and passes into the gastrointestinal tract, usually the duodenum. And this results in small bowel obstruction as the stone migrates distally down the small bowel loops. There's a classic description of Riegler's triad, which composes of small bowel obstruction, aerobilia, as well as ectopic gallstone seen within the bowel loops. And normally this gallstone is located in points of narrowing, luminal narrowing within the bowel loop, typically seen either in the duodenum, the ligament of Treitz, the ileocecal junction, or in the sigmoid colon. Typically, the gallstone can potentially be surrounded by gas within the bowel loop, although that's variable in appearance. Cholesterol stones are usually near water density and often with a calcified rim. So on imaging, you would appreciate that there will be a collapsed gallbladder with pneumobilia and a dilated bowel loop with a transition point where the impacted gallstone is located. So in this example that I have here, this is a patient with a radiograph that shows dilated small bowel loops. And on the CT that was done subsequently, you can see that there is a fairly dense gallstone that's located within the ileum. We can appreciate the presence of aerobilia within the intrahepatic bile ducts. And in the region of the upper abdomen, there's also a very large fistula between the gallbladder as well as the duodenum. Another case of gallstone ileus, you can see again in the plain radiographs, dilated small bowel loops. There's also some aerobilia that can be appreciated in the upper abdomen as well as plain gallstone in the upper right quadrant. And on the CT scan, you can see that there's aerobilia within the gallbladder. There's still a remnant calculus seen within the gallbladder. However, in the lower abdomen, you can see that there are impacted gallstones within the lumen of the small bowel loops. And on the coronal scan, you can appreciate the presence of dilated small bowel loops. We move on to bazoas. These are well-recognized but uncommon causes of small bowel obstruction, probably composing about 4% of cases. And these are composed of partially or undigested food material, and is formed due to the large fiber intake, inadequate chewing or mastication, and reduced gastric motility. It is prevalent among patients with delayed gastric emptying, such as patients who have gone through a previous vagotomy or gastrectomy, or due to autonomic dysfunction from conditions such as diabetes. Most of small bowel bazoas are located in the ileum because that's where the lumen is the narrowest. And different types of bazoas have been described depending on the composition of the bazoa, so such as phytobazoa, which is predominantly vegetable or plant material, trichobazoas, which is hair, and lactobazoas, which occurs in small children is composed of milk powder. So this is an example of a patient who presented with clinical signs and symptoms of small bowel obstruction. On the plain radiograph, you can see that there are dilated small bowel loops in the left hemi-abdomen, air fluid levels on the erect view. On the CT scan, there was a transition point that was seen in the lower abdomen. And the reason in the region of the transition point, you don't really see anything too striking, except for the fact there's probably a small little gas locule seen just proximal to the transition point. However, as the patient's symptoms continued to worsen, this patient was taken to surgery. And on surgery, the surgeons found a rather interesting lesion within the lumen of the small bowel, and was postulated that this could be an atapchi seed, which is actually a type of dessert that is quite popular in Singapore. So at the same time, the surgeons also did the endoscopy and also showed that there was a mushroom bezoar that was located within the duodenum, and this was eventually fished out and looks like a shiitake mushroom. We move on to intramural causes. And most commonly, intramural causes would be composed of intestinal malignancies. And this is an example of a patient who presented with intestinal obstruction. And on the CT scan, the cause of the obstruction is due to a very proximally located colonic tumor, and in the presence of an incompetent ileocecal junction, this also resulted in dilatation of the small bowel loops. Another example of a tumor this time arising from the third segment of the duodenum. It causes dilatation of the bile ducts. You can see that the common duct is dilated, and there was also diffuse dilatation of the stomach as well as the duodenum. And this was eventually histology was performed and showed adenocarcinoma arising from the duodenum. This is a rather interesting case. It's a middle-aged patient presented with this radiograph, very diffusely dilated small bowel loops. If I may show the CT scan. Okay. So I've taken just the lower cuts of the CT scan. You can see that there are dilated small bowel loops, and the transition point is located within the pelvis, where there is very large necrotic mass in the lower pelvis. And on scrolling, it actually connects with a bowel loop that's diffusely thickened and long segment in appearance. This was an interesting case. We postulated that this could be due to either a necrotic gist or a lymphoma, given the long segment appearance and the possible aneurysmal dilatation. However, this patient declined further investigation, as she was not keen on any further investigation. As such, we were unable to obtain the formal diagnosis. Other causes of intramural obstruction would be due to strictures, and this can be due to a variety of causes. Like Dr. Yi said previously, Crohn's disease is a common cause of strictures within the small bowel loops. Other causes of small bowel strictures would be due to radiotherapy or previous surgery. So this is an example of a patient who has a history of Crohn's disease. You can see there's a stricture in one of the distal small bowel loops, which is causing proximal small bowel dilatation. We move on to extrinsic causes, and this can be broadly divided into several groups. The common ones would be due to hernias, and hernias again can be divided into external hernias as well as internal hernias. We have adhesions, which is a very common cause of extrinsic small bowel obstruction, as well as extrinsic matters. So in terms of abdominal hernias, many hernias have been described. In our clinical practice, inguinal as well as femoral hernias are the most common entities. And it's a common cause of intestinal obstruction when the small bowel loop or any kind of bowel loop is trapped within an incarcerated hernia. And this can result in closed loop obstruction, closed loop type of obstruction, as the bowel loop within the hernia sac is obstructed at 2 points. And in the presence of closed loop obstruction, strangulation or ischemia of the bowel loop is a potential complication. So this is an example of a patient who presented with small bowel obstruction due to a left inguinal hernia. You can see that the hernia sac is located in the inguinal region. It is also medial to the inferior epigastric vessels, which would indicate that this is probably a direct type of inguinal hernia. Also notice that on the right side, there's another smaller hernia that contains fluid. This is an example of a femoral hernia, which is causing small bowel obstruction. The neck of the hernia is located inferior to the inguinal ligament, and the sac contains a loop of small bowel that is causing obstruction. Another rather rare type of external hernia that one may encounter would be an obturator type of hernia. You can see that in this patient, there on the very last image on the coronal plane, you can see that there is dilated small bowel loops. And in the lower pelvic region, the cause of the obstruction is due to a loop of bowel that's herniating through the right obturator foramen. And that's that small little knuckle of small bowel that is entrapped within the obturator hernia sac. And this is clinically important because the surgeons will be able to feel an inguinal and a femoral hernia. But in a case of an obturator hernia, the surgeons will not be able to detect the presence of a sac because it's too deeply located within the muscles. So this is an example where the radiologist plays an important role in finding out what's the cause of the small bowel obstruction. Internal hernias are generally rare in our clinical practice, and this is due to a herniation of bowel through a mesenteric defect, congenital bend, or a normal anatomical opening. It can be due to acquired causes such as post-surgical or iatrogenic or post-traumatic causes. The more common types of internal hernias would be the paraduodenal hernias. Other rarer types of internal hernias would be internal hernias into the foramen of Winslow, pericecal hernias, or transomental hernias. And really the diagnostic clue to diagnosing an internal hernia would be looking for a cluster of dilated small bowel loops within the abdominal cavity that's associated with distorted mesenteric vessels. So this example of a left paraduodenal hernia, you can see there's a cluster of small bowel loops in the left upper quadrant, and the yellow arrow points towards the left colic as well as the inferior mesenteric veins, which is the landmark vessel to diagnose a left paraduodenal hernia. So this would, on imaging, this would appear as an encapsulated cluster of small bowel loops located between the pancreatic body and tail and the stomach, usually to the left of the ligament of Triads. And the bowel loops in general hernia into a sac that's created due to a potential space between the descending as well as the distal transverse mesocolon. And like I said earlier, the IMV as well as the left colic vessels or artery lies anterior and the medial border of the hernia sac. Adhesions are due to pathological bonds between surfaces, and this is a thin film of connective tissue. Can be either a thin film of connective tissue or it could be thick fibrous bridges. And 70 to 90% of peritoneal adhesions are due to previous abdominal surgery. So this is an important history to find out whenever you're reading a scan and the form request is due to is suspected small bowel intestinal obstruction. Adhesions themselves are not really identified on CT. They are beyond the resolution of CT, but it can be suspected if there's no other obstructing mass or other cause identified, and if there's a sharp transitional or acute angulation of the bowel loops. So this is an example of a patient who had previous intestinal surgery in the past and presented with small bowel loop dilatation. You can see that on the CT, on the axial slices of the CT, there are multiple dilated small bowel loops. And if I may point out, there's a sharp kink and angulation to some of the bowel loops, which is also corresponds to where the transition point is. And so this was due to adhesions, and it was proven eventually on surgery. Okay, we move on to one more cause of external or extrinsic causes of small bowel obstruction. That is due to peritoneal metastases. And peritoneal serosal metastases are one of the more common malignant causes of small bowel obstruction. Primary sites of the tumor usually could come from the gastrointestinal tract or gynecological tracts. And the cause of the obstruction could be due to extrinsic compression or impairment of peristalsis. So in this patient, we have a patient who had a history of pancreatic cancer, and this right now presents with symptoms of intestinal obstruction. On the CT scan, the yellow arrows point to areas of soft tissue thickening and nodules, which you can see in the umbilical region as well as in the right lower quadrant. And these are causing intestinal obstruction. And this patient had a history of pancreatic cancer. So the reason for the obstruction in this patient would be due to peritoneal disease. So when reading scans where the request form states that there's presence of intestinal obstruction. It's important to include in the report what the surgeon needs to know. So the surgeons will need to know where is the location of the transition point and whether there's a presence of a closed loop obstruction, because that would indicate that this patient is at greater risk of perforation or bowel ischemia. Now, of course, we want to look for other complications such as perforation and bowel ischemia. So a closed loop obstruction is diagnosed when you have dilated bowel loops with two discrete transition points that are close to each other. And as I mentioned earlier, these, because of the nature of the obstruction, these patients are at high risk of perforation and ischemia. So in this patient, had previous abdominal surgery in the past, and this for this current presentation presents with intestinal obstruction. You can appreciate that there are dilated bowel loops in the abdomen and pelvis. And if you look at closely on the right hemi-abdomen, some of the small bowel loops are actually demonstrating reduced mural enhancement, and that is a sign that is suspicious for intestinal suspicious for bowel ischemia. The yellow arrows point to where the transition points are, and unfortunately, because this is single images, it's a bit difficult to appreciate where the transition points are. But there are actually two transition points, and they are closely located to each other. So this was surgically proven to be a closed loop obstruction due to the presence of adhesions. Perforation is also another potential complication of intestinal obstruction, and here we have another patient who unfortunately developed perforation of the small bowel loops due to long-standing obstruction. You can see that there's tiny gas locules within the small bowel mesentery. So some useful advice that I give to my junior residents when they are reading scans such as this. I frequently get asked, how do I look for the transition point? So some advice that I give them is to look at where the dilated loops are predominantly located. Are they located predominantly in the upper abdomen or in the lower abdomen? Look for, if it's near the lower abdomen, then trace retrogradely from the large bowel loops to the terminal ileum and see whether you can find the transition point. Look for where the collapsed bowel loops are, because that will also give you a clue as to the location of the transition point. Small bowel fecalization sign is also a good sign to look for, because that is usually located near where the transition point is located. And if you have multiplanar reformats, that will be very helpful for junior radiologists in looking for the transition point. So in conclusion, small bowel obstruction is a common surgical emergency, and it's important for radiologists to be able to diagnose correctly, know the causes, as well as the potential complications. And that's my last slide. Thank you very much.
So thank you so much, Dr. Lu, for your nice presentation.